Hello and welcome to the COMLEX Instant Review. Please visit comlexflashcards.com for free resources, including daily blog posts, podcasts, and video lectures as you prepare for the COMLEX board exam. Let's get started, and today's topic is going to be heparin-induced thrombocytopenia. HIT is an immune-mediated complication of anticoagulation therapy following the administration of unfractionated or low molecular weight heparin, resulting in thrombosis, thrombocytopenia, and skin necrosis. There's several types. Type 1 is within the first 2 days of heparin administration. Smaller fall in platelet number, it's non-immune, platelets return to normal with continued heparin, and there's no clinical consequence here. Type 2 is an immune complex mediated, and it's heparin-associated immune thrombocytopenia, heparin-associated thrombocytopenia and thrombosis, and white clot syndrome. Also, thrombocytopenia through platelet consumption is what happens here, and significant risk of both morbidity and mortality results here. Now, the incidence of unfractionated heparin is mainly less than 4 days, or 0.2%, and for unfractionated heparin given greater than 4 days, you have 2.6% by meta-analysis. And 4 factors in addition to duration increase the risk of developing HIT. That is, using unfractionated heparin greater than low molecular weight heparin, surgical risk, female, and prior exposure. All those factors can increase your risk of developing HIT. So as you're reading the question on the board exam, make sure you hone down on certain characteristics. Has the patient been on unfractionated heparin? Have they had any recent surgeries? Is there a history of skin necrosis and all the physical manifestations? Prior exposure can be as little as 250 ml heparin flush or coated catheter, and so this is really important. Typically, this occurs between 5 and 10 days following heparin exposure. It's mediated by immune complexes formed between heparin PF4 and IgG, IgM, or IgA antibodies specific to these paired molecules. Complexes first bind platelets through heparin receptors. Subsequently, Fc regions of antibodies bind CD32 receptors on the platelet surface, activating platelets and to release alpha granules with more PF4. Okay, and here's a diagram showing you the exact pathophysiology. As you can see, you have the blood vessel here, and then there's heparin-like molecules coming out here, and when heparin is given, there's a complex, PF4 and heparin complex, that's formed. This, along with the IgG antibodies, forms PF4 heparin IgG complexes and results in platelet activation. Now, there's also a PF4 release finally from these platelets, and that cycle keeps on going back and back again. Here you can see this platelet binding to the heparin-like molecule. HIT from 5 to 10 days after initiating therapy, as antibodies form from days 5 and 8. Delayed onset HIT averages 9 days after heparin withdrawal, and early onset could be as much as 1 to 3 months. Clinical manifestations include thrombocytopenia, and that's the key clue on the test. Thrombocytopenia in HIT typically greater than 20,000. Okay, the median is 60,000. And so you want to keep sure you know that number as you're looking at the board exam question. 20,000 or greater. And there's thrombosis, which is greater in the venous portion than the arterial. Subsequent 30-day risk of thrombosis is 53%. Initial sign is usually thrombocytopenia. There's venous manifestations like DVT, PE, limb gangrene, upper extremity DVTs. All these are venous manifestations. But the initial sign is thrombocytopenia, and then you can have a thrombosis. Arterial manifestations less commonly cause stroke, MI, and acute limb ischemia. Also skin necrosis, usually fat-rich areas, but can affect distal extremities or nose. And patients have erythema, purpura, hemorrhage, and necrosis. Rarely adrenal hemorrhage from venous stasis or transient global amnesia also results. You want to suspect HIT in patients on heparin during the last 5 to 10 days or on prolonged low molecular weight heparin. If there's an unexplained onset of thrombocytopenia, also venous or arterial thrombosis resulting from that thrombocytopenia, and a platelet count which has dropped 50% or more from a prior value, even if absolute thrombocytopenia is not present, along with necrotic skin changes at the heparin injection sites and acute systemic anaphylactoid reactions like fevers, chills, tachycardia, hypertension, dyspnea. All these are factors that you want to keep in mind when suspecting HIT. There's 3 primary tests you can do: a serotonin release assay, a heparin-induced platelet aggregation, a solid phase immunoassay. And for the treatment, immediately stop all the heparin. Patients must be anticoagulated secondary to continued risk of thrombosis. An alternative initial anticoagulation with direct thrombin inhibitors like lepuridine, bivalirudine, or argatroban, in addition to fondaparinux, can be given. So let's take a look at this algorithm. You suspect HIT, immediately you're going to stop all forms of heparin, and then you're going to start ongoing anticoagulation. If you do that, then you want to make sure that you use an agent such as a thrombin inhibitor like lepuridine. Okay. Again, this is an algorithm that you should follow if you suspect HIT immediately. Lepuridine must be carefully dosed in renal insufficiency, so watch the creatinine if it's greater than 1.0. Argatroban must be specifically dosed with hepatic dysfunction. Okay, so patients with either renal or hepatic dysfunction, you always want to be careful. And bivalirudine is dialysable. Okay, and finally, patients must be transitioned to warfarin for long-term anticoagulation. And that's a key point. So if a board exam gives you the scenario of a patient with HIT, then make sure you also consider the warfarin as long-term anticoagulation. Do not transition the patient to warfarin unless the patient is stably anticoagulated with a thrombin inhibitor and the platelet count has risen to at least 150,000. So that's why you want to wait until these 2 criteria are met before starting the warfarin. And ensure a minimum of 5-day overlap between warfarin and thrombin inhibitors, and do not initiate warfarin alone as it increases the risk of venous limb gangrene and DVT. The use of heparin after HIT. Well, you may be used as long as the duration is brief. Okay, that's the key here. And obviously after you've taken care of all the post-treatment and made sure that they're on long-term anticoagulation, their platelet counts are normalized, then you may consider this. You can use the assay for PF4 heparin antibodies show that HIT antibodies are no longer detectable. Okay, so you can use tests to make sure, and usually they're gone after 50 to 80 days following the last exposure, but a safer interval is to wait 100 days. Also, you can use alternatives whenever possible, and you can only use unfractionated heparin when it's necessary for the procedure. Again, thank you for listening to the COMLEX Instant Review. Please visit COMLEXFlashcards.com for COMLEX prep resources and subscribe to our blog at www.comlexflashcards.com. Good luck in your preparation for the board exam.